The bedside swallow evaluation. What should be included? The bedside swallow evaluation, also known as the clinical swallow evaluation, or abbreviated CSE, is a critical first step when it comes to assessing swallow functioning and formulating a solid plan of care. As we all know, however, an assessment at the bedside doesn't give us X-ray vision. So what should we include in a bedside swallow evaluation to make sure we're capturing as much useful, evidence-based, and relevant information to the patient and their swallow? Let's dive in. I'm Theresa Richard. I've been a medical speech pathologist for 15 years. I'm a board-certified specialist in swallowing and swallowing disorders. I'm the founder and CEO of the Med SLP Collective and Med SLP Education. Now, before you even give your patient something to eat or drink, you have to investigate. Here's what should be included in your investigation process: the chart review, the primary diagnosis or reason for admission, comorbidities and past medical history, past surgical history, current diet, labs, imaging, vital signs, prior speech therapy notes if present, and allergies. Consult with the nurse and referring physician. What is their greatest concern? Any observations of difficulty during meals or pill administration? Any limitations you need to be aware of before going in to do the assessment? For example, contact precautions, airborne precautions, hip precautions. The patient interview, symptom report or quality of life questionnaires. A short handful of examples include the Mann Assessment of Swallowing Ability, or the MASA, for patients with stroke, the Pill-5 for patients who complain of pill dysphagia, the Eating Assessment Tool, or EAT-10, Reflux Symptom Index if they present with upper GI or reflux complaints. If possible, the caregiver interview. What have they observed? Now, let's move on to the non-PO assessments, as in what you'll need to evaluate before giving any ice chips, liquids, or solids. You'll want to do things like the cranial nerve exam, cough assessment, motor speech exam, assess body structures and functioning. For example, is the patient using the accessory muscles to breathe? Are they fatigued? Do they lean to one side? Any neglect? Can they feed themselves or adjust themselves in bed? A cognitive communication screen. Can they follow instructions? Are they alert? Environmental or personal factors. Do they avoid certain types of food? Are there any religious or cultural considerations related to diet or nourishment? I'll be posting other videos just like this one that you won't want to miss, so make sure to hit that like and subscribe button and turn on the notification bell. Also, do you have any specific questions about the bedside swallow evaluation? Leave a comment below and tell me about it. We'll be sure to get your questions answered as soon as possible. Now it's time to look at how they swallow and feed themselves. Make sure oral care is provided prior to introducing any food or liquid. The Yale Swallow Protocol is often used. It's also referred to as the 3-ounce water test. Based on your clinical judgment, assess various food textures. Observe ability to self-feed, maintain lip closure, chew the food, and control the food or propel the bolus back to the throat. Check for oral residue or pocketing. Remember, you cannot see what's happening in the pharynx or esophagus. Just because the patient never coughs doesn't mean they're not aspirating. This is where you combine all of your data to make an informed decision on the next step. Is there any concern for dysphagia? Consider an instrumental. Is there absolutely no history or concern for the development of dysphagia or any dysphagia-related illnesses? An instrumental might not be needed then. Don't forget to keep your goals patient-centered. If there is a high suspicion for dysphagia or aspiration, or maybe the patient coughs frequently during meals, ask what the patient wants. Patients have the right to choose how they wish to proceed. If they want to keep eating and drinking their normal diet, knowing that they're likely aspirating, they have that right. This video explains that the CSE can have so much value, but we ultimately can't describe pharyngeal dysphagia with this information alone, and we need to get an instrumental assessment. I always say I'm never surprised by what I see on an instrumental because I'm always surprised. I can't tell you the amount of times we thought everything would be crystal clear and they were silently aspirating everything, Alternatively, based on the CSE, we assumed their pharyngeal swallow was a mess and it ended up being fully functional, which then tells us that what we're seeing clinically does not correlate with what's really going on the inside. I've got a free gift for you over at medslpcollective.com. You'll get instant access to our free Med SLP Collective clipboard kit, which includes our editorial-reviewed clinical swallow examination resource. We also have a robust and vibrant community of SLPs and mentors to help you with your toughest clinical cases. Head over to medslpcollective.com now to get your hands on it, and the link will be in the description below.